Hi, everybody. Welcome. My name is Monique Luley, and I'm a vice president at Santis, and I'm really glad you could join us today. We have some great panelists and some great discussion ahead, and we'll get started right away so that we make the best use of the next hour of our time. So first and foremost, of course, I'd like to ask that those of us calling in from across Turtle Island, especially those of us calling in from the land known as Canada, just to take a moment now to acknowledge the ancestral lands where you're situated. I'm here today on the unceded territory of the Anishinaabe Algonquin, and I express gratitude to the First Peoples that have had this land under its stewardship for millennia. I'd like to also acknowledge all First Nation, Inuit, Métis people for their valuable contribution to this land. All right, so just a little bit about me. My name is Monique Luley, and I will be the moderator today. I'm the vice president at Santis. And Santis Health, just to tell you a little bit about Santis Health, we are a consultancy that provides counsel and support to clients exclusively in the health and life sciences sectors. And we're quite laser focused on the work that we do in that sector and have been doing so for over a decade. So our three big buckets of work are within strategy and policy development. So we are, valuable and trusted advisors to building both strong public and private sector relationships. We also work in communications and stakeholder engagement and in government relations and advocacy. So today, as you know, we are here to talk about solutions in the acute care sector. And without further ado, I'd love to, first of all, thank Medline and Roger Bourbonnais, who will say hello in a few minutes, and also just introduce the panelists today. So I'm going to start from out west. Out in Alberta. Dr. Kathleen Ross is president-elect of the Canadian Medical Association. She's a family physician in Coquitlam and New Westminster, British Columbia. I said Alberta. My apologies. I just moved you from Alberta to British Columbia in the last sentence. She does clinical work in community primary care and obstetrics, surgical assist work, including cardiovascular surgery at the Royal Columbian Hospital. She has numerous leadership roles, and she has the opportunity to establish healthcare policy and lead grassroots improvement in both community and acute care. She is recognized for her interest in advancing technology at the front line and in clinical care. She has served as physician lead and chair of the Pathways Patient Referral Association from inception to its current state as an indispensable online clinical and referral tool for physicians in BC and the Yukon. Next, Dr. Michel Michaud is president of the New Brunswick Medical Society. Dr. Michel Michaud is a family physician, palliative care physician, pain care physician, and hospitalist at the Edmundston Regional Hospital. Dr. Michaud grew up in Edmundston, and she completed her undergraduate degree in 2003. She received her medical training at the Université de Laval, earning her medical degree in 2008 and completing her residency in family medicine in 2010 before being recruited to practice in Edmundston. Dr. Michaud has been active with the New Brunswick Medical Society for many years as a member of the negotiations committee and a member of its executive. She joined the board of directors in 2014 and was nominated president-elect in 2021. As current president, Dr. Michaud advocates for enhanced access to primary and specialty care and for innovative solutions to critical health human resource shortages. And finally, Tammy DiGiovanni is the Senior Vice President and Chief Nursing Executive for the Children's Hospital of Eastern Ontario. Tammy started at the Children's Hospital of Eastern Ontario, CHEO, in 1995 as registered nurse, working on the inpatient surgical unit, as well as the emergency department. She has since served in leadership roles across the organization, from inpatient medicine to health records and e-health. For many years, Tammy led the ambulatory care portfolio and was a leader of our electronic health record implementation as Chief Nurse Information Officer. Tammy joined the executive team in 2021 in the role of Senior Vice President and Chief Nursing Executive. Her portfolio includes critical care and surgical services, inpatient medicine, hematology, oncology, ambulatory care, pharmacy, and the emergency department. She also supports the Champlain Maternal Newborn Regional Program, as well as the National Newcomer Navigation Network. As chief nurse, she's proud to be working with the dynamic and professional nursing team throughout CHEO. So, as you can tell, we've got a dynamic panel today. First, though, I'd like to again thank the sponsor. And Roger, if you don't mind saying a few words.
Sure. Thank you, Monique. So Medline Canada, we're excited to be sponsoring this webinar today. So it brings together, obviously, some very talented panelists to help us find solutions to the challenges we face in Canada's healthcare system. So these are the types of conversations that we really believe in having at Medline. So our focus is on together improving care. We believe in creating partnerships to address the needs of our customers, as well to improve patient outcomes. As a leading medical products manufacturer and distributor in this country, we're proud to serve acute care settings, primary care, long-term care, retailers, and much more. But we believe in providing more than just medical supplies. Our team has decades of practical and clinical experience that we bring to the table to help find solutions. So at Medline, we're about discussing ideas to find the best way forward. And that's why we're very proud to sponsor today's conversation. I would like to personally thank you all for attending.
Roger, thank you so much, and thank you to Medline for bringing this group together. And although the Prime Minister and all the premiers are meeting together starting about now, I'm pretty sure that this conversation will be just as impactful. All right, so let me kick off the conversation with that in mind. The premiers and prime minister are meeting today in Ottawa down the street, and they're taking a look at funding agreements for healthcare. And although we won't focus a lot on funding agreements today, we know that there are a lot of challenges facing the entire system right now. Just out of like a general statement, what are you hoping comes out of this first conversation? We do know that this isn't there's not going to be a decision today by any means, but what are you hoping comes out of the conversation today? Maybe I'll start with you, Kathleen.
Thank you very much. So I'm really hoping that we can come out of today's announcement and today's discussions between us with some concrete plans and steps forward. We know what the problems are. Lack of access to primary care, difficulties accessing surgery and imaging. These are a long wait list. These are challenges that we have, a lack of portability in our healthcare workforce. So investment is needed, absolutely, but we need to rethink how we deliver care to try and best meet the needs of Canadians.
Thank you. Tammy, did you want to add anything?
Yeah, I mean, coming from the Children's Hospital, we're committed to kids' health. And so for me, really looking at, what is the government's commitment to advancing pediatric health? And, frankly, I think that will require brave action. I don't know that there's some quick fixes to do that. We had lots in the news, and we experienced the devastating impacts when the system's not right-sized for kids. And this was decades in the making, not just the last few months. And so the fixes will take longer than a 4-year electoral cycle. And I think we just need to be committed to that, to be looking at what investments can we make that will lead to better health outcomes. And not only that pediatric health is on the radar, but that the investments are really tied to outcomes, that we're committed as a nation to raising the bar for children and youth. And so that's about right-sizing the system. It's about being innovative and doing things differently than we have in the past, because we failed kids and youth in this country. And, whatever we invest now will reap the benefits for generations to come. And that will serve us all well for the economy and for healthcare. So for me, I'd like the long-term approach and be looking at what we're doing for kids and youth.
I love that, Tammy, and I'm looking forward to chatting a little bit more about that long game for sure. All right, Michelle.
Well, I think for me, I come from a small province, a rural region, and I do think we really, really need to have targeted funds for primary care reform. I do think we really need to find ways to bring those family physicians into community practices and better support them so they can actually do their job of seeing patients instead of doing other things. So this is for sure one of the things I hope for.
I love it. Yeah. And those rural areas, certainly there are many in Canada. We're a big country. So I appreciate that comment. Just want to let everybody know who's listening in that there is a little function that you can add in a question, and we're hoping to save a few minutes at the end to answer one or two. So if you have a question that's burning, feel free to just add it into that little function. All right. So one of the benefits of having the three of you on is that you do span, a large part of the country. And I'm always very cognizant when I say that the far north is not on this panel. So I know that you have experience. Each of you have some experience with the far north. So feel free to bring those experiences in as well. But as you think about all these premiers gathering, is it the same problem across the country? Do you think there are regional considerations? And if you could speak to that, and maybe I'll pick up where you left off, Michelle, in talking about rural and the smaller areas of the country. And what are you hoping that the premiers coming from the Atlantic are bringing to the table today?
So one of the things is we are the only official bilingual province in Canada, in New Brunswick, and this is affecting some of the healthcare resources. It's challenging for our province, and it's affecting also recruitment. So we will need to find ways to better attract physicians, but also other allied professionals to work in those provinces where it might be more difficult in the future. We also have one of the most rapidly aging population in Canada. This rapidly aging is also one of the most chronically ill population. So like complex care takes more time. That means less visit, and it does increase the human resources shortage that we are seeing across Canada. We are also one of the most aged population of physicians in Canada, and we are seeing a lot of them might be retiring in the near future. We also know that the new physicians do not work in the same way as older physicians. They have a larger practices for most of them, but we also are practicing differently now. So we will need to figure out how to ratio the replacement of those older physicians in the near future. And those are all things that might create even more of a larger human resources difficulties for small provinces across Canada.
Thank you. Tammy, Ontario gets a lot of the news. The Prime Minister's office is in Ontario, and it's such a large province. Everything is perfect in Ontario, but can you find anything at all that you're hoping the Premier is going to discuss specific to this region?
Yeah, so it's interesting because we typically talk about healthcare as being provincial and each province having different needs, which is interesting because it's regulated that way and it's funded that way. But I think we can all agree that the needs aren't really unique to provincial borders, and it's really about the communities. And you mentioned Michelle, the rural, we have northern, we have urban, different socioeconomic classes. And so if we want innovative solutions, we have to give people the freedom to innovate. And I don't think that's province-wide. I think that's at a more granular level. And so there's all of the human resource issues and issues that apply in New Brunswick and on the east. I think we have different issues, but similar themes. And so how are we learning, but giving the giving the system and the microsystems the ability to innovate to what meets the population needs. Because we have examples and of best practices. We've got patients and families and healthcare workers coming together with innovative solutions. We need to give them the freedom to innovate and be able to make that work.
I love that. I love that idea and thinking across provincial boundaries. Kathleen, as the president-elect of the Canadian Medical Association, you've got a nice wide view of what's happening across the country. Would you agree with Tammy's sentiments that certainly there are some regional considerations, but that the themes of the issues span the country?
I absolutely agree, and you're probably aware that Deloitte worked with the CMA earlier this year to release a report that said exactly that. We are much more similar across the provinces in our country than we are dissimilar. Many of the challenges that we face in British Columbia, rural or urban, are faced in all areas across the country. And we do need to support innovative models of care, expand those areas where we've seen success. The team-based care model is critically important. There are many things that I do as a family physician that I could delegate to a nurse or to a social worker or to a psychologist to try and free me up to see additional patients. And yesterday I worked in a clinic that often I have two nurses working with me in one of our maternity clinics, and neither were there in the morning. And boy, did it slow things down and left a great deal more work to be done at the end of the day. We know these models work, and there are excellent examples across the country. The challenge is in funding those models appropriately. And the next big challenge is Michelle spoke about that as well, is touching on the human health resource challenge that we have. At the moment, because we don't have a robust data tracking system, we don't even know how many workers are doing what kind of services and where they are delivering those and how they are supported. So we need to have that human resource data tracking for certain. And then we need to have a way to track our outcomes. Where is our money going, and what are we actually getting in the way of population health for those outcomes, for us to better understand where we need to innovate. I'll make one more comment. One of the things that I see as a physician working in quality improvement is the value of the grassroots small team test of change, and then expanding out and spreading those successes across jurisdictions. But there is a missing piece here, which is sharing that knowledge and success across jurisdictions nationally, not just within our regions. We can learn from each other. We just need to have the funding and support to do it.
Thanks so much, Kathleen. And I do want to stay with you for the next question, because when you were going for the president-elect, you had said it was your belief that because of the attention being brought to the healthcare sector as a result of the pandemic, there's an opportunity for doctors to help reform the healthcare system and address the root causes of primary care crisis and the backlog of acute care. What do you mean by that? Can you maybe think about some of the, have there been efforts to remedy those struggles, and tell us a little bit about that?
So as I said earlier, I don't think our challenges in our healthcare system are new, and we have definitely seen them highlighted more throughout the pandemic. There's nothing like a good crisis to show you where your gaps are and where people fall through the gaps. The need is dire right now, that we need to understand what delivery of services at the front line mean. What does it mean when someone doesn't have a family doctor and has a new lump or bump or cancer or other critical illness that needs to be attended to? How does that person navigate the system? What does it mean when one of our seniors presents in the emergency department without a link back out after their treatment into community care? We have every idea what our patients need on the front line, and those of us providing care on the front line can speak up now. I feel like we've been empowered by this recent crisis that we've been in to speak our truths of what we see and what is needed, both from a clinician point of view, so physicians, nurses, right down to the people ordering supplies in the hospital. Everyone has an understanding of where the gaps are now, and I've seen a revolution in the last 3 years of really focusing down and bringing that patient voice into the conversations. So ask the front lines and the patients what they need and work with us to provide it.
That's great. Any of you want to make a comment on that?
I had exactly the same comment. I think we were we're happy to see a lot of engagement and leadership coming out of our physicians across Canada at a much needed time where our population, our patient needed it. We were reminded also of the importance of listening to the frontline workers across Canada during the pandemic, and that how we could do really good things even in big crises. So we have, yes, a complicated health system, and we sometimes think that, oh, well, it's complicated. We have a big system and not every province work in the same way. But I think the pandemic has shown us that we actually can do terrific things and work really rapidly on situations. So I think we need to pivot the way we address the pandemic and address the crisis we're living now. And for me, and maybe I'm wrong, but most of the crisis we're seeing across Canada is primary care access and human resources shortage. So we need to pivot those crises and address them rapidly, because yes, we are still in crisis across Canada now.
Yeah, and I want to get back to you on that as well, in terms of the human resource crisis. Tammy, full disclosure for those of you that don't know, I did work with Tammy, and she is phenomenal at CHEO. So you've been there for over 25 years, Tammy, and you're also a member of the Board of Health for Ottawa Public Health Unit. So you were pretty poised in quite a position during this pandemic, and I never want to talk about it in past tense, at least not yet. Can you paint a picture for us about the most striking change you've seen as a result of the pandemic in children's hospitals or among your colleagues across hospitals? And in your opinion, what would be some suggestions, either further to what Dr. Ross has presented, to help your teams on the ground?
Yes, so much to unpack there, Monique.
I know.
A really great question. And, much like Kathleen and Michelle were saying, the pandemic, the pandemic just blew open cracks that everybody that works in the system knew were there. And so, the hospitals tend to serve as a safety net when primary care is failing. Public health, when it's at its best, is doing its job and preventing, illnesses way upstream and looking at the health of a population. We only turn our attention to public health when we're in a crisis. And, so all of those things existed. So if you ask any health professional, we were worried about critical care capacity, wait lists, emergency volumes, primary care long before the pandemic, and the system really wasn't right-sized. And then we witnessed what happened with that, specific to kids in the last few months, but that's on the heels of 3 years. And I don't know that we really paid attention to population changes and the health system responding to those population changes. And we talked about the team, and you're right, Kathleen, we always sort of thought about primary care as a family doc, and really effective primary care is a team sport. And so our health system hasn't really changed to acknowledge that, and to acknowledge that, the role of, receptionists and support staff, clinical and non-clinical, working together so that everyone's working to scope and, doing the right thing for the patient. The system just hasn't responded that way or been built that way. And I think that's really what we need to pay attention to. We've made great strides in some areas. And so, when CHEO was opened 45, 50 years ago, we had 300 beds. And so, there's been great strides in, anesthesia support and diagnostic imaging and, surgical services, so that we don't need to admit as many kids as we used to, which is phenomenal. right now we have 150 beds. And so it was right to have kids home earlier and not admit them to hospital. But now with 150 beds, it's not right sized for a growing population, for, much more complex needs. To be admitted to hospital, you have to be really sick and very complicated. It's not right sized for that. And so I think it's really about looking at the health system generally and saying, it's not about cost containment, it's about an investment in population health. And that's at every level. And we just haven't done that. If we've learned one thing through this pandemic across Canada is if we don't have a strong health system, we don't have a strong economy, we don't have a strong education system. And that's our future. That's our future. From an economic sense, it's our future in terms of, our kids and our family, and that just has ripple impacts to every level of society. And if we haven't learned that in the last 3 years, then we really need to be thinking about where we're setting our priorities.
Yeah, Kathleen or Michelle, do you have some comments on that? I think to Tammy's point about those cracks were already there, and maybe the voices weren't being listened to, but now it's very, very difficult to ignore that. And specifically talking about this sort of interprofessional teamwork, and really, nurse practitioners and physician aides and now that I've named 2, I should be naming every single assistant and regulated health professional that's such a valuable. You think about the respiratory therapist during a respiratory illness. There are so many untapped potential in terms of the interprofessional disciplines. Can neither of you comment on that and how you feel that we should be thinking about the model of care differently?
So I'll take a stab at that if I can do. Thank you. I mean, both Michelle and I work in multidisciplinary teams. From as a family physician, my interests are from birth all the way to death, so a little bit wider scope. But we have these gaps everywhere, so not just in child and youth, but actually also at the end of life as well. One of the things that we see blocking hospital beds continuously is patients who are alternate level of care that could be transferred home. If there was sufficient, home care support for those patients. And I see this all the time. I've seen in my own family where people linger in hospital longer than they need to. If we could support them better at home, they would be happier and healthier and cost the system considerably less by working in those teams. There are examples across the country where there are outreach nurses that go into the homes and feed back into our primary care teams. There are examples of physician assistants in many parts of Canada that are acting as physician extenders, and in some cases, alongside advanced practice paramedics that are the only source of care in some rural areas. But it has to be part of a team, and patients need to be familiar with who's gonna deliver their care and where they call first. And these are systems that we can enhance. And I will pick up also on a point you made, Tammy, about healthcare system that's healthy is healthy for our economy. In fact, our healthcare system is a major economic driver across the country, and in some places, particularly smaller towns, the healthcare system may be one of the major employers in those towns. So we can't speak about the economy and the healthcare separately. They're intimately intertwined. Michelle, you want to add?
On those gaps, I think what we need to remind is that communication between different parties is so important, and we've seen great success too at the beginning of the pandemic. I can only think of, for instance, for alternate level of care at the beginning when we were at the start of the pandemic. Every hospital was running around and trying to find ways to get those patients out of the hospital so we could have more beds in case. And we worked really well with social development and regional health authorities to find those beds and send those patients to other places. Was it home? Was it nursing home? Was it adult facilities? But we did it and we supported them. And I think for most part, it went well. So we are able to do nice things. We just need to figure out how to do them on a regular basis now.
Yes, sticking with you, Michelle, I think that, we're starting to touch, and you had touched earlier on health human resources, and it's difficult to think about solutions without thinking about the people that are going to be doing the work. And I really appreciate and saw firsthand the incredible passion and the incredible drive of people who were working on the front lines throughout the past 3 years. And every time I thought, how much more can people take? They seem to be able to reach deeper and help each other out when colleagues were sick and calling in sick and unable to come to work, and they had to do another shift. And, it's, but it is taking its toll. And in fact, on the workforce itself, people either leaving or maybe choosing not to go into the field at all now. And I'm just wondering, certainly there's the teamwork aspect, but thinking a little bit more about first of all, everybody that works across healthcare, whether that's the cleaners, the IT, the finance people, the accounting people, there's a wide breadth. But are we doing a good enough job of supporting them across the country? And this is where I wonder about the boundaries and the college designations and the professional and education requirements. How do we start thinking about new ways to attract people at this really incredible, attract and retain at this really critical stage of health human resource shortages?
So like we said before, I think the collaborative model is probably the answer to go from the first part to the next. I think the correct answer for physicians is the same for all professionals and workers across Canada and into the hospitals. So we need to find ways to make better teams and better support for our patients and better support for our workers too. So in the same way, we need to support better family physicians. We need to make sure that they work less in silos and facilitate the way that they can do and work collaboratively into practices and be supported with allied professionals so they can actually do their job. We need to find ways to integrate nurses, assistant physicians, scribes, and other allies to work with the physicians so we can actually diminish overburden of administrative tasks that we have and diminish the paperwork that we have so we can actually create access for a patient and be there and be physicians. But that in the same way, if we think of nurses in the hospital, we need to find ways for them to be able to work in team-based environment where they can be supported. They have other allied professionals. It can be a beneficiary attendants or LPNs, but we need to have them better supported. The same way, physiotherapists, we can have kinesiology and other allied professionals that can help them see all of their patients and treat everybody. I think it's just we need more bodies to help those professionals, but it's not necessarily, we won't be finding professionals tomorrow and resources tomorrow. So we need to support those that we want, that we have, so they can do their work efficiently and be seeing patients instead of doing paperwork and charts and doing things that are not their scope of practice. Nurses do a lot of things that are not necessarily in their scope of practice, and it's actually some of those things that are causing the overburden and the burnouts. So I think supporting us, working collaboratively in the healthcare is the solution. We just need to have the support financially and locally. Like we said, we need to start small and every solution is not necessarily the same for everybody, and it won't be working the same way in my rural region as another city. But I think those are the solutions on the long run if we want to have a sustainable system.
Mm-hmm. So before I go to the two of you for further comment, and I hear that a lot, Michelle, in terms of the burden of the extra paperwork and the extra reporting, and we want to be collecting good data and we want to be measuring the right things. Are those at odds with each other? Is there a tension between collecting data and getting really good outcome measurement and reducing paperwork. Tell me a little bit about how we circle that square.
So technology. So I think it's easy, and we need to simplify things and simplify technology. And it's not because I'm not the one writing in the chart. It doesn't mean it hasn't been done and it's not done correctly. And the data is still there and it can be used. But the thing is, it needs to be integrated together. So I use one technology, she uses another technology, and they don't talk together. Well, we haven't done much. But we need to find ways to work with technology and integrate information so we can actually have data sharing that creates better information for patient, better information for the physician seeing the patient, and then creates better access too. So it's not more complicated, but we just need to
Right
do it.
stuff. Yeah. Tammy, do you talk a little bit about, yeah.
Yeah, we were chatting actually just before the panel got started, because you know, you can take by province, but even, you know, at the federal level, like we're a single payer system, with a lot of funding in healthcare, and yet we aren't behaving like we're a single payer system. And so, you know, you wouldn't have a major bank not knowing information about their clients because they're in, you know, Vancouver versus Toronto. They have a single system. Why we don't for healthcare is a bit beyond me. And so, you know, the technology exists. We haven't been bold to say, this is how we're going to proceed, because the data is important, and because we need to look at population health, and because, you know, if you can take this on so many levels, but look at vaccination. We still use paper cards to register, you know, lifelong vaccines. And we expect, you know, parents to not only keep those cards up to date, but, you know, pass them on to their 18-year-old to go to university and have them updated through the lifetime. It's crazy that we don't have a national registry for vaccines. And that's one issue. Imagine the power if we had all of our information integrated and we could make informed decisions about where the best investments would be, what the outcomes are for those investments, and where we have, you know, pockets of excellence, and what are they doing, and how can we replicate that across the country. It's mind-blowing to me that we haven't, as a country, come forward with that, mining that amount of information, because that will help us at a macro level, but it will help the individual providers as well, because you're not, you know, having fax machines and looking for that paper and maybe having to scan things in and enter the data because it's not in the right format. It's crazy what we do to provide patient care. We're doing better, I think, in, you know, sort of small, like, you know, hospitals are now, you know, with integrated systems, extending perhaps into, you know, regions, but we're not looking at this at a system level, when really that's really what's needed. But that's bold.
I love the comment you just made, Tammy, that we're doing better, at least within hospitals. We're talking, like, people would have probably assumed hospitals were even at least integrated, and that wasn't even the case 10 years ago. Kathleen, you know, in this, and I dare say any of this, but in this high misinformation, fear of my private information, fear of my even getting a vaccine, in light of this, Big Brother is watching and Big Brother is not, you know, doing good things. How do we get a system that instills trust in people, that even though the information is across the country and the reason that it's there is to make better informed evidence-based decisions, that we can really reassure Canadians that their information is private, that the systems are secure? Cybersecurity isn't an idle threat. We have seen really examples recently of big hospitals that have had to go down because of cybersecurity threats. Do you think about that at all?
Constantly. But I think that there's a bit of a generational gap as well. Certainly in my children's demographic, those folks are a little less worried about privacy, security. They want access, they want service, they want to be able to see what tests they had done when and what their record showed. So the patient carrying that information is certainly one solution, but the interoperability is really critical. And they're quite right. The technology exists. As I was saying before the webinar started, I work in 3 separate sites, and none of those 3 sites actually speak to each other. And there's a gap there, and oftentimes some results may get sent to the wrong office even. So I have to go onto 2 separate sites and look and see where did the result get sent, so that I can best care for the patient that's in front of me. The privacy and security is something I think we must all take seriously. But I think there are absolutely ways to gather the data that we need, the metrics that we need to drive our quality improvement throughout the system without disclosing, individual level data. That sort of macro data is just as valuable as drilling down into the individual. But I think these are discussions that we need to have. Having a national repository on how many vaccines have been deployed is certainly one example of that. But how many diabetics are actually accessing routine care? How many of our diabetics have seen an eye doctor in the last 2 years? These are things we can get ahead of. How many of our young people have not received their human papillomavirus in school and are now at risk for 5 different cancers? Where's the knowledge saving and investing in universal vaccination programs that support proven vaccines to reduce disease, including HPV vaccine as a great example. HPV vaccine reduces the risk of 5 different cancers, including head and neck cancers, and yet many of Canadians have not had access to it, or inability to pay for the expensive vaccine to reduce those upstream costs. These are all preventative aspects that we could start to work on if we had the appropriate access to data.
Boy, Kathleen, those are such practical examples. Like every one that you said just went, oh, that just makes so much sense. So thank you for, giving, because I think people hear about all this data collection and they don't know what that actually means. And to your point, Michelle, having a visit to the eye doctor by someone who's diabetic isn't the eye doctor writing more reports. It's that the information of the coding of that visit goes into a central repository and gets collected at a macro level. So really, really great examples. And I really appreciate that. And these to me are some of the solutions. And I just want to take a minute before we get into our speed round of thinking about some of the things that have been said here so far. So thinking about, there are themes across the country and solutions across the country that we're not tapping into. I heard that today. Making better use of interprofessional and team models. And even from a recruitment and retainment, I talk often with people when I'm doing any kind of professional development or performance maps. I always ask 2 questions. Do you have a friend at work? And would you to ask a friend to come and work with you here? And I think that over this past 3 years, people have lots of friends at work. We have really bonded together in healthcare. But in terms of saying, would I recruit a friend? I don't know if people would because the professions are so difficult right now. Continuing to track data in some very, very good examples. The word came out twice, Tammy. Be bold, be brave. I love that. That's exactly what we need. We need to start thinking about those outcomes because that's going to help in what we can do from a population-based health. What's working? What can we do for the whole population? Starting to think about quality improvement measures and sharing those across the jurisdiction. Empowered to speak truth, listen to the front line. I keep hearing they're doing good things, and if for no other reason than gratitude, they should be heard about what they've gone through over the last few years and what has worked. And these aren't new issues. These are cracks that were already there that have opened up into big trenches. And then thinking, of course, that although we're a single pay model, we don't have a single digital system that collects all this information and helps each other to support each other in this work. What great themes. Oh my goodness. Thank you for these. Now, as we started, we know that the Prime Minister and the premiers are meeting. I've connected with the RCMP. They're going to let us go speakerphone right into their meeting. We're going to interrupt their conversation, and you each get to tell us a big wish of what you would like the premiers and the Prime Minister to discuss and find some resolution on. So feel free to be bold. These are wishes, and we'll let them figure out how to implement them. But I'm going to let me start. I don't think I've started with you yet, Tammy, being in the center of the country, in terms of what it is that you would like the Prime Minister and the premiers to hear on this wish round.
Well, I have to say, Monique, you've got a lot of power to just get us right into the
Right?
room. So
I know, it's great.
It's, to me, it's to pick up on a theme we were just talking about, and it is to, listen, recognize, and stand up for healthcare workers. When I say healthcare workers, I mean nurses, physicians, cleaning staff, administrators. Like we've been talking about, the solutions exist, and people get into healthcare because they want to make a difference. And if we're not listening and instilling hope for the future, then we're going to kill our pipeline. Want and are willing to make the jump into healthcare. And so I think that is really, really important. What's the plan, and respecting the people that are in the system to deliver on that.
Thank you. And I think that there are a lot of people that are happy that you have their back on that one, because I think that that's what we were seeing in terms of big shortages is people that have had a lot on their shoulders in the last few years. Michelle, over to you. What's your big wish?
I have
Or
many
wishes. That's okay.
I have many, but I think I said it before, but I'll say it again. I think we really, really need to have investment in collaborative practice models to better support the community of physicians across Canada and create better access. That would be one. I think for supporting what Tammy just said, I think improving workplace culture for healthcare workers across Canada is one big thing. We've seen a lot of overworked, overtired workers across Canada, and I think we really need to be more supportive, make sure that the environment is really well, because it's the future of our healthcare system, and if we don't, we won't be able to recruit or retain the physicians, but also healthcare workers. And the other one is probably more a personal one, but
Go for it.
I would wish for reducing any administrative burdens on physicians. I think we really, really need to, for the future of our profession, we need to find solutions for that, making accessible scribes, as physician assistants, to make sure that we are supported better and we can do other things than paperwork.
Thank you. Thanks for that. All right, Kathleen. And just want to remind people to go ahead and submit any questions. We'll likely have about 5 or 7 minutes left to answer one or two. Yeah, Kathleen, go ahead.
So I'm going to echo many of the same sentiments. Obviously, I'm looking for investment to support pan-Canadian licensure of our healthcare workforce so that we can move people where we need them most, and that will take some investment. Investing in physically and psychologically safe workplaces for all healthcare workers so that our healthcare workforce wants to run to work in these places rather than dropping and running and leaving early. And that will require flexibility and some funding. And then finally, as a big data geek, data, we need a national health data and human resource strategy to address our gaps in care, our retention, recruitment, deployment and training of healthcare workers, and really laser beam focus on the needs of Canadians.
Yeah, I really appreciate that comment and those national strategies. We didn't dwell on those today too much, but certainly having somebody thinking about the big picture long term would be really ideal. I see one comment in the Q&A chat in terms of a big wish, and I love it. We might as well get everybody's wishes in, is how to leverage a better connection between scientific research, policy making, and operational support. We often see the lack of evidence to inform the policy and the resource allocation. I love that. And we didn't talk too much about the role of research in terms of policy making and in terms of where this fits in this creating of a sustainable healthcare system. Does anybody want to comment on that?
Go ahead, Michelle.
I would say if we have better technology, we can have better data, then research might be really more possible. I think it's really difficult for researchers right now to find the data that they need. They really need to be on site and search a lot. And for technology now, it's so easy. So we just need to have data more available.
Yeah.
And I was going to highlight the need to have those collaborative discussions with the frontline providers, physicians, et cetera, to drive the policy makers' decisions and discussions. We need to be included. We need to be at the table. And the other piece that I would say is I find often research is a bit too slow. So I'm much more interested in the iterative learning healthcare system that comes with the Plan, Do, Study, Act cycle of short iterative quality improvement measures.
Interesting.
Yeah, I agree with you, Kathleen. I think oftentimes we think about research as being the moonshot, the big new discovery, the big new advance, and that's important. It's incredibly important. But this iterative piece where you're looking at the system, understanding the metrics, making incremental change, that's when you look back in 5 years and say, wow, I can't believe all the change we've made, as opposed to really over analyzing and being pure in the research. I think we need to have pure research, but also really applied and iterative research that then feeds into what we do operationally and also feeds into how we change and shape policy going forward.
Yeah, I love it. Very good. Okay, I don't know if there are any other questions. I know there was that one in the chat, but I didn't know if there was another function somewhere that someone else sees.
There's a few other comments.
Ah, okay. Oh, I see. Oh, yes, this is why. Okay, very good. We also need to introduce policy science much earlier in nursing education. Tammy, tell me a little bit of what your thoughts are on that.
Yeah, I couldn't agree more. I think there is a lot rightfully in the nursing curriculum. And now that it is, a university level curriculum, we need to be thinking about how we balance off, having engagement in policy development and really be empowering nurses the earliest stages about how they can inform change. And so that is around policy and, how do you impact policy and drive policy? It's also about, like we were talking about, quality improvement is when you're out in the workforce, how is it that you can be a leader at the bedside and be driving some of those changes that will ultimately make a difference to patient care? And how do we create the systems that allow nurses, but all health professionals, to have the bandwidth and the time for that creative thinking? And I think that's really key in how we change the system going forward, but it's also key to how we retain and engage professionals in being, validated for the ideas that they have and seeing the changes take place. I really do think that's key, and it has to start with our undergraduate curriculum, but also be continued as people start in the workforce.
Love it. Yeah. Christy says, on behalf of the Canadian Association of Physician Assistants, we're looking for government to invest in PA education. PAs are physician extenders. Extending their role will greatly enhance the capacity of the healthcare system. You're getting a lot of knowledge.
Absolutely. Absolutely. There is enough work for everyone. We need all hands on deck. And I think that looking at setting those standards as to what constitutes a healthcare worker and what their scope of practice is across the country. We haven't touched on pharmacists much, but that's another untouched resource. There's a lot of work, and we need everybody.
I agree. And the days of having these territorial fights for scope of practice are gone. You just need to really, who is on board, what can they contribute to the health and the care for patients, and how can we best use those skills? We've had fantastic success with physician assistants, and I know of many other success stories. So absolutely, I think there's an appetite there.
Yeah, and I would add to that we need to stop talking as an either or. Michelle's spoken quite eloquently about the need for team-based care and everybody working together. We know that patients already have a family physician or primary care provider. They may have a nurse in the community. They may have a psychologist. They may have a pharmacist. Think of the power of all of those people working together in one team.
That's amazing. Okay, so, and I just want to credit, there were a couple that were anonymous, but Liliana was the one who asked about the policy science earlier in nursing education. So thanks for that comment, Liliana. You know, I want to say that I've been in healthcare a really, really long time, and always have been very grateful for all the people that work in healthcare. And I want to also just acknowledge the leadership of this panel. All of you had to make time for this conversation. It wasn't extra time in your day, and didn't lead to any improvement today. But I do think that these conversations are really, really important to continue the conversation, to have people who are, listening and really thinking about solutions on a day-to-day basis, as the three of you and many of your colleagues throughout the system are. Thank you. Be very, very well. Take care of yourselves. We need you for a long time in these positions, and thank you for the teams you lead. Thank you to Medline for sponsoring this conversation. There will be a little, what do we call those, surveys? So let us know how we did today, and what else you would like us to present on. And again, I thank you, Michelle, merci, and Tammy, thank you. I know personally how hard you work, and so I thank you for all of your work. And of course, Kathleen, for taking this new leadership role and having such a national voice. Thank you very much. I'm going to continue to be bold. Have a great day, everyone.
Thank you, everybody. Have a good day.
Thank you.
Bye all.
Bye-bye.